sessions. So thank you very much, everybody, and welcome. I'm very pleased to introduce our webinar for this evening on emergency medicine. We'll be focusing on emergency medicine this week. And emergency medicine is very much a team sport, and it's very lovely to have two presenters that's going to be facilitating this together. So we are very pleased to welcome Dr. Mary Hoffe and Dr. Nicola McCreesh here from the Eastern Cape. And they are both emergency medicine physicians, a very rare breed in the Eastern Cape. And they are based in Gqeberha, or the old used to be known as Port Elizabeth, at Livingstone Hospital. And Livingstone Hospital is the only specialist-run emergency department in the Eastern Cape. So I'm sure many of our rural provinces knows that most of our emergency medicine are done by medical officers or family physicians in sort of district hospital settings, and even many of our regional hospitals are managed through medical officers. So Dr. Hoffe and Dr. McCreesh both specialized in the Western Cape, but they've now since relocated to practice in this more resource-restricted setting. And in practicing in this setting, they describe as a privilege and sometimes a curse, but it highlights the need for improved emergency care in the more remote parts of the country. And their goal is to extend evidence-based emergency care into the rest of the province and country by empowering and inspiring younger doctors and advocating for more specialist-run centers beyond major metropoles. They're both very passionate about their speciality and would like all patients to receive excellent emergency care regardless of their postal code, or even if they have a postal code. So being part of programs like this and empowering junior doctors is an honor, as they describe it, and it helps to improve care in the most remote parts of the country. And it's just to emphasize that all of our facilitators that contribute to the rural onboarding all give their time voluntarily, and they have spent effort to put together this presentation for us this evening, where we're going to be focusing specifically on the airway. So I would like to therefore hand over to Dr. Hoffe and Dr. McCreesh, and thank you very much for joining us this evening.
Hey, evening everyone. Guys. So I'm Nicola, this is Mary, if you want to creep in. So we have chosen Airway as our emergency medicine talk for tonight. We think it's very important because airway is sort of your make or break. If a patient needs airway control, you have the opportunity to do something really well. And if it's not done really well, you can do a lot of harm. So there is a blog, which I love, and it's called The Laryngoscope as a Murder Weapon, and it really can be a murder weapon. So we want to go through everything to make sure you do no harm and that your airways run smoothly. So Mary, if we're talking about airway, why would you get an advanced airway for your patient?
Well, Nicola, I think I'm going to just ask you before we go on to that, is what actually is an advanced airway?
Okay, so to me, an advanced airway is anything that is adding to our airway. So it could be an LMA, it could just be an OPA. It's anything that's assisting us with airway. But there is a definitive airway, and the definitive airway is, the definition is basically a cupped tube below the level of the vocal cords. And this prevents aspiration. As you can see, the trachea is completely sealed off, and anything from the esophagus will not be able to enter the trachea. So you can see in both diagrams, the cupped tube beyond the vocal cords. But that is a definitive airway, and we're talking all airway today. So once again, why would you get an airway?
So I think when we are discussing getting an airway, I'm often talking about getting a definitive airway. The other airways are often things that would assist us in oxygenating or assist us in placing that airway, such as LMAs or oropharyngeal airways. But essentially, when we're talking about getting an airway, we're talking about getting in that definitive airway. And for me, Nicola, I think there are three reasons why I would want to get a definitive airway. So firstly is there an airway problem? So is there any obstruction in my airway that is preventing that oxygen from getting to the lungs? So that could be anything from, say, angioedema or anaphylaxis, where there's swelling of that airway, or potentially a foreign body in that airway. Or is there an expanding hematoma from neck trauma, or a tumor or something externally sort of obstructing my airway? Another one, which we often talk about, which is sort of a part of also airway obstruction is your comatose patient, your patient with very low GCS, where they just can't maintain their own airway, keep their own airway open. So that's just their tongue is literally falling back. They're so comatose, their muscles, they're not maintaining the airway. So often that's a point when I need to get a definitive airway. So is there an airway problem? And then the next one is the ventilation problem. So now the airway may be intact, but is there sick lungs? Do they have pneumonia, COVID, ARDS, pulmonary edema? Something that's preventing that gaseous exchange and preventing them from oxygenating. That I might need to assist with, and often with the ventilator, and try and improve that oxygenation. Or are they just not ventilating? So maybe they've had too much sedation, or they've taken an overdose of an opioid or something, and they're not ventilating, and I actually need to breathe for them. And at that point, I'll also need to place a definitive airway. And then the last one is really, it's maybe just thinking a little bit ahead. Maybe they don't need an airway right now, but could they potentially need an airway in the near future? And I think those ones, especially for the guys sort of in the rural areas where you often may be having to transfer these patients to more district or tertiary level care, it's very important to think, is my patient potentially going to deteriorate in that transfer? And although maybe their airway is maintained now, or they're ventilating adequately, sort of borderline at the moment, maybe I need to think ahead and intubate them now so that they can get safely to their destination. Obviously, the other classic one we probably hear is the CT scanner. No one wants to be intubating in the CT scanner. So sometimes, even if you don't need an airway right now, it's important for us to think ahead and be proactive, and rather do it now than later. Maybe another classic one is burns patient or angioedema or something where maybe not now, but critically in the near future, they may lose that airway. And rather, let's get an airway in now when it's safe than when the airway is so swollen because of those burns that I can't get the tube in. And now I'm stuck and having to think further and doing things like surgical cuts. So that's the reasons why I would get an airway. And as we said, I think that airways are very important. So, and we also said that we can potentially heal people by getting an airway. So I think importantly is to prepare.
Yeah.
So Nicola, do you want to take us through some of our 5 Ps?
Yeah, let's do this. So it's prepare, prepare, prepare. Failing to prepare is preparing to fail. So we have mnemonics, because we love mnemonics in emergency medicine. And we're going to talk prepare 3 times. So first, you're going to prepare your patient. This is the other mnemonic. So when you prepare your patient, you need to think lemons. Is my patient a lemon? And it's quite easy. L is for look. So look at your patient, look externally, look internally, look all around. Do they have a beard? Do they have a goiter? Do they have a mass? How big is their chin? How big is their tongue? What do their teeth look like? Any of these things going to cause problems. E for lemon is evaluate. So it's that 3-3-2 rule that you heard about in anesthetics. So 3 fingers in the mouth, 3 fingers underneath the chin, and 2 fingers between the hyoid bone and thyroid cartilage. Pretty useless in emergency medicine. We don't often ask our patients to open their mouth and see if we can stick 3 fingers in. It doesn't really help us. And it's the same as the M. So the M in lemon is malampati. And we don't ask our patients to sit upright and open their mouth and see how much of their palatine fossa we can see. It's just not practical. But it is just to keep you, just to remind you about the things we need to look for. But importantly, obstruction. So perhaps think of a foreign body inside the airway or compression from outside the airway. And N is for neck mobility, very important in emergency medicine. A lot of the patients you are going to intubate are trauma patients, and most of our trauma patients that we intubate are polytrauma patients, and a lot of them are in C-spine immobilization, which means your airway is difficult from the get-go. No, this is a difficult airway. But other people who have decreased neck mobility are your elderly patients, your patients with ankylosing spondylitis, your patients with osteoarthritis. So think about the neck mobility that might hinder your patient's neck mobility. So you're wanting to prepare for the difficult patient and think lemons, but you need to further prepare. And now we need to prepare our environment. And we use another mnemonic. This one I think you might have heard of. Well, actually, no, I think you might have heard of stop icy bars. And we have changed it to stop ice bars in our unit. And we'll go over the E as we go through the preparation.
Exactly, and I think important about preparation, and you can hear we are mentioning quite a few mnemonics, which may be easy to remember, may not be, but it's important about having an approach. And if it's what we have in our unit, we actually have these on the wall. So something to think about in your units, in your casualties or ECs, is to actually put up these mnemonics and have up on your walls that is easily visible and easily seen in the moment. So if you do forget, you can easily look and you can go approach. Okay, I need to think, is this a difficult airway? Let me go through lemons. Okay, I need to prepare my equipment. Here's stop icy bars. Let me go through it. So on that note, I think let's go through stop icy bars. So S stands for suction. So
Rigid one, floppy one. What do you want, Mary?
So for an airway, I most definitely want this rigid one. So this is what we often call your Yanka. So this, I will say now, this is a PEDS one. So if you're intubating an adult, this is the incorrect size. So ideally, you want to have an adult size Yanka in your resus trolley. They are essentially firm, and the aim is that when you're going in to look at your vocal cords, that you can suction any blood or gunk or secretions that could be obscuring your view. So you want something that's firm, that you can easily place in the right place to suction, that's got a nice and big enough hole to be able to suction up whatever gunk is down there, rather than this floppy one. So this is more likely to actually suction inside your tube once you've actually intubated the patient. But in the moment when you're actually trying to remove secretions and clear that view of your vocal cords, you don't want to be using this flimsy suction catheter trying to get it in the right place in the back of the throat. You also, if it's too small, you're not going to be able to suction up what you need to suction up. So just make sure that you have these, and preferably an adult one, and I guess in your PEDS trolley, a PEDS one, but a PEDS one will probably not really ideal for an adult. You might not get to the back of the throat.
But you mentioned several times that it's under visualization. So you never suction blindly, you always suction where you can see. You do not stick a suction tube somewhere that you can't see. So ST, tubes.
So tubes. Nicola, what tubes would you like for your patient?
I want all of the tubes. I want 3 tubes for every patient. So if I have an adult male, I want to probably intubate him with about a size 7.5, maybe an 8. And so I want a tube size above and a tube size below. And a female, I'm thinking a 7.5. So I want a tube size below and above. So a 6.5, a 7, a 7.5, etc. But I don't just want my tubes. I need my tubes to be checked. So the tube that I choose, the 7.5, let me just adjust this. I am going to open, but I'm going to leave it inside the box whilst I check the cuff. So take a syringe and I'm going to inflate the cuff. So I've inflated the cuff and I'm going to check it. Once I've checked it, I'm then going to leave the syringe on it. Have you forgotten to check a cuff before?
So I think I've been lucky, Nick. I think at times I've forgotten to check the cuff, but I've been lucky enough not to run into problems with it. But really, we're all about being prepared. And the last thing you want to have done is got your airway in, got through the tube, through the cords, got your ET tubing, and then you blow up the cuff and realize that there's a hole in the cuff and there's some manufacturing defect. So very importantly, check your cuff, mainly on the tube you're going to use, but have the other tubes available. You might still have them in their packaging because you can't afford maybe to open up all your tubes and check them all every time, but there should be at least another 2 sort of readily available should that first tube not fit. But don't forget to blow up your cuff, and then it's a nice idea just to keep that syringe on your cuff so that when it comes to actually inside your patient and you want to blow up that cuff, you can find the syringe, because also they don't want to have that syringe rolled off onto the floor and now you want to secure and you want to inflate your cuff and you can't find the syringe. So it's all about being prepared and hopefully having everything in place. So the next one is oxygen. So very importantly, often we are intubating patients because of an oxygenation problem. So you want to make sure you have oxygen. So obviously make sure you've got wall oxygen, you've got a Christmas tree attached, you've got your oxygen tubing that will go through and reach your patient, and then your different oxygen delivery devices. So often, especially for pre-oxygenation, just having a non-rebreather available and a face mask to assist with pre-oxygenation, especially in your patients that are breathing spontaneously. And then you're going to need probably something like a bag mask valve. So make sure every resus trolley should have one, and we'll go into checking it just now, but obviously make sure it's attached to oxygen, it's the appropriate size, and that you've got one readily available. You may need this in pre-oxygenation, but you'll definitely need it once you've intubated the patient. Then other things that you might want, which can be also useful maybe in a more sort of hypoxic, difficult intubation, if you've got them and know how to use it. It's something, this is a CPAP mask, sorry, it is in its packaging, but you might also want other oxygen delivery devices, such as a CPAP mask to assist you with pre-oxygenation. So the next one really is in our preparation is position and pharmacology. Do you want to take us through positioning your patient?
Okay, so when we keep talking about all the things that'll make your life easier. So when you position your patient, you'd like to line up the airway to make it as easy as possible, so that when you stick the laryngoscope in their throat, in the vallecula, and you lift up that epiglottis, you see the vocal cords beautifully, and you can just slide it down. And as you can see, that picture on the left-hand side shows that access beautifully. And then you can see actually that head is sort of hyperextended. And so the picture on the right-hand side shows how we can do that. Basically, every single patient, easy or difficult airway, large or small, you want to try line up the tragus of the ear with the sternum of the chest. So you want to get that line together. And how we do it is exactly how the picture shows. So either we use the bed and we can sort of slightly elevate the bed, but you usually do need to get blankets, pillows, vacuolators, whatever you can, just to stack underneath the back of the patient. And if you line up that airway, when you open and you visualize the vocal cords, you should be able to see them beautifully.
Exactly. I think you really want your first attempt to be your best attempt. So prepare, position your patient. Obviously, the caveat here is your C-spine immobilization in trauma patients, and that's why they fall under a difficult airway, and there will always be a difficult airway, because unfortunately your positioning you can't do. So that's one caveat.
So with our P, we are doing pharmacology. So we thought we haven't thrown everything in here, but we've thrown the most common drugs in here. So your two drugs you need a paralytic agent and you need an induction agent. Remember, we do drug-induced or drug-assisted airways these days. Mary, do you want to tell us about what sort of your favorites and when you choose what?
Yeah, so as we said, you need a paralytic and an induction. And paralytic, we've really only got two choices. We've got rock and we've got sax. So often sax is a favorite in many ways because of its short duration of action. So I guess the hope is that if you do run into trouble and you can't get your airway, it's a much shorter apneic period, and that you can hopefully bag a patient through that. The caveat to that is that you can't always trust that. Sometimes your sax may go on for longer, so don't hang your hat on that. Also, often actually you prefer the prolonged maybe because that helps you get ventilator synchrony. The other thought often was that sax is a shorter onset than rocuronium, but in the EC we actually use a higher dose of rock than you might see in anesthetics. So we go up to 1 to 1.2 milligrams per kg to try and decrease that onset time. Both of them, we say actually 45 seconds to a minute of onset, even for your sax. So often people run into problems because you give your paralytic agent, you give your induction agent, and then immediately you try and intubate. And if you haven't given time for them to be paralyzed and the muscles to relax, you're not going to intubate your patient. And that also comes very importantly in your pre-oxygenation, and the fact that every patient, when you're intubating them, is probably going to have at least 45 seconds to a minute of apneic time, if not longer, while you're actually doing the intubation process. The other thing you might have all heard of, and is a contraindication to keep in mind with sax, is that potential for hyperkalemia. So in patients that are hyperkalemic already or at risk for it, like your CKDs or your chronic kidney disease or your burns, not necessarily immediately, but like 24 to 48 hours afterwards, or your spinal cord injuries, also 24 to 48 hours afterwards, that are at higher risk, are things to keep in mind when picking your agent. Obviously, with your induction agents, the key three we've got on here is ketamine, etomidate, and propofol. For me, and I think many EC doctors will agree that ketamine is really our friend. It's really our go-to drug. It's got analgesic and induction properties. And there always used to be that worry about ketamine increasing your intracranial pressure, not to use in trauma patients or head injury patients. That is not really the case. That is being tabooed. You're welcome to use ketamine, and we would recommend it for trauma patients. The reason we like ketamine is really it's technically hemodynamically stable. It does actually increase your blood pressure and increases your heart rate, which is maybe something to keep in mind for your patients with, like your older patients with like maybe some coronary injury, previous MIs. But otherwise, it's a relatively safe drug to use. The other one of that is etomidate, which is also essentially hemodynamically stable. And then the other one on this is propofol, which is probably in the EC, the last go-to of drugs to intubate a patient because it causes hypertension. And essentially most of our EC intubations are in hemodynamically unstable patients. So we're not going to use a drug that's going to worsen that. A caveat for all of these drugs is that if anybody is actually on the extremis of their like hemodynamically instability, all of these drugs could actually potentially decrease your blood pressure, heart rate, and cause further instability. So we pick the one that's most likely going to assist us the most, but they actually all do in the end have that potential. I think the key really is to get to know a drug. So pick a paralytic agent, pick an induction agent, get to know it well, know its indications, know its contraindications, know its dose, and know it well and use it. Much better to use one that you know well than to pick one that you've never used before and don't know. So I think that would be my biggest recommendation here.
Yeah. Okay, so we are actually through the stop and we're moving on to the ICE. So the I is for IV lines, have them and make sure they're working. The C is for cardiac monitors, but we want all the monitors. So we want a continuous ECG monitor, we want a blood pressure cuff going up, we want a SATS probe, and if we have a capnography. The SATS also continuous, and the BP should be cycling every 1 to 2 minutes, particularly around that pre-intubation and post-intubation period. You want to know what your hemodynamics are doing. So all the monitors, all the IV lines, and then E, as I mentioned, is we have added E's to make it stop ICE bars instead of stop IC bars. And the reason we added E was because we found that there was no equipment check in this mnemonic. And really, this is where all of the issues sort of came from. And two big things to check was one, your laryngoscope. Do you know how to check it? And have you checked it? So I don't have a normal laryngoscope here. I unfortunately have a video laryngoscope, but I'm going to use it as though it was a normal laryngoscope. So when you grab your laryngoscope out the trolley, I say, please check it. Everybody opens it up and has a look and goes, ooh, the light, it's shining. And they never really think about, well, when am I using this? When does my light go off? And they go, oh, the light is good. We'll turn that light off. When the light goes out is generally when you put it into your patient's mouth. So you have now put it in and you lift up on the hard palate, and then the light starts to flicker or starts to go out. So you want to check your laryngoscope with pressure holding down on your blade. You want to have a look at that bulb. If it stays solid, great. If it doesn't, check that it's actually screwed in properly, because some of them actually screw out and screw in. You don't want it falling out. And if it's not, if it's flickering, you need to change your handle, change your batteries. So when you grab your laryngoscope, you want to, one, check your laryngoscope, two, have an extra handle or batteries depending on what you have. Make sure the bulb is there, and have several blade sizes. So just remember, you should have it.
watching that nonsense for bed.
Someone else is joining in on the airway.
Okay, but yes, exactly. So key is to check with that downward pressure. We actually, one of our ones in the unit over the weekend did turn off when we checked it on gauge downward pressure, but thankfully we checked it before we were intubating, and we managed to get a new handle and blade and managed to sort it out. Because the last thing you want to do is have visualized your cords and to try and lift up that glasses to get in the tube and it all goes black.
Load shedding.
Yeah, load shedding, exactly. Load shedding in the back, that's right.
It's not pleasant.
No. I think the next equipment to check, we've already mentioned the BVM, but it's also important to make sure your BVM is actually working. So just the few quick tips checking. Firstly, you've got your reservoir bag. Make sure your reservoir bag is attached, because they do often detach. So make sure you've got the correct one with the correct fitting and that it fits. It doesn't have a hole, which means that when you connect it to oxygen at 15 liters, the bag should inflate and fill up. You then want to just check that there's no leak in your bag. So an easy way to do that is to just put your hand over the outlet of your BBM. If you've got a peephole, which hopefully you do, you also just want to close that peephole. So if you can, both your hands, that helps. And then you just try and push. And if you can't bag and the bag is firm and you can't put any pressure or deflate that bag, you've got no leaks. Then you also maybe just want to check that your peephole is working. So you can release your peephole and just make sure it does pop off, just so you don't cause any Gqeberha volume. But that's the quick, easy way to quickly check your bag. So make sure your bag's working, because once again, you don't want to get your tube in and come to trying to bag a patient and realize you don't have a bag.
That is the pressure release valve that pops off.
Yes.
Yeah.
What else with the
Not the peep valve,
Sorry,
but it's the pressure release valve that pops off.
Yeah.
There are peak connections, so if you have one, that's great. Just know how to turn it on. It's very nice to have with a bag.
And I guess what comes with the bag, I forget, is also the masks. So make sure you want a variety of tubes. Hopefully you've got a variety of masks in your resus trolley, so you can pick the right fit for your patient. So basically, you don't want it too long that it comes off over the chin, and you don't want it too high that it covers your eyes and your face and you end up bagging the forehead. So you want to be able to get a good seal. So obviously people are different sizes. So ideally you also want a variety of these and to select the right one for your patient.
Okay, now we move on to bars. So B stands for bougie. Which is the bougie? Is it the blue one or the green one or both? Are they both bougies?
So I don't know if you can see here. So basically this one here, this green one, is the bougie. The reason why this one is the bougie is generally your bougie is longer, but it's also a little bit floppier. And it has a little what we call hockey stick end. I don't know if you can see it here, but the aim for the bougie is to one of your difficult airways assist devices. So if you can't get the best view of your vocal cords and you can only see your original, your posterior of your vocal cords, the hope is that if you aim for that area, this little hockey stick with a sort of anterior point will assist you to get the bougie through the actual vocal cords. Key thing to remember with your bougie is, which makes it different to an introducer, is you use your bougie without your ET tube attached. So you only place your ET tube and you railroad your ET tube on once your bougie's in place. And another very important thing about using a bougie and how to railroad it is with anything airway, you don't want to lose your visualization. So once you've got that bougie in and you saw it go through the cords, you don't want to take your eyes off it until you secured your tube, which means that you definitely need an assistant who can hopefully, I'll ask Nicola to do it, but while I'm watching the cords, making sure my bougie doesn't move, my assistant will railroad down the ET tube, and once it's at my hand, I can then continue moving it in. So you will keep your laryngoscope in the mouth, watching the whole time until you see your tube through the cords, and then you can remove your bougie and inflate your tube, inflate your cuff. So that is the bougie. Nicola, do you want to discuss this little introducer?
Yeah, so mine is the introducer. And as you said, so this is long and floppy, and this is much shorter, and it's far more rigid. So the bougie you intubate with, the introducer you put into the tube and you intubate with the tube. So it fits very nicely into your tube like that. And it just helps with molding your tube. So if you have a very anterior airway, you may want to mold the tip of your tube. A lot of the times when people are using video laryngoscopes, they like to mold the tube to the laryngoscope. Importantly here, this one's very nice. You actually can't push the introducer past the tip of the ET tube, because otherwise you can damage the airway quite a bit. This is a really nice one. It actually sits on the top here. But if they're very tight, you also might just want to use some KY jelly on them, because there's nothing worse than having an introducer help you put the airway in, and then when you pull the introducer out, you take your airway out too. Okay, so introducer versus bougie. Both get out of jail free cards. Both we say you should do on your easy airways continuously. Practice on your easy airways. We sort of basically say do a bougie railroaded tube with every tube. And so you get into the habit, because it's probably one of the most simple things that is going to help you. And if you are in the district, in the rural areas, they're cheap, and then maybe your only get out of jail free card. Hopefully you have one of the other ones coming up, but yeah, that's a good one to know.
Exactly, and use them on the easy airways so that when you come to the difficult one, you're comfortable with using that equipment. The next one on our,
We need Henry for this one.
oh yes,
Let's
okay.
bring Henry.
So here's Henry. So Henry is our little little man here, our little dog. He's just going to help us show you our next thing on the stop IC bars, which is our airways. So we've got our OP airways and our nasopharyngeal. So our oropharyngeal and our nasopharyngeal airways. Okay, so I can show you quickly. I'm sure we've all seen these, often also referred to as Gqeberhas, but these are your OP airways. Essentially, the aim for these is to assist with getting oxygen from the mouth into the back of the throat in a potentially sort of comatose patient that's not maintaining their airway. Remember, they will induce a gag reflex. So if they aren't comatose, or they depending on their GCS, they might not tolerate one of these OP airways. And they often use them when we're trying to bag a patient to improve pre-oxygenation before we intubate. So important though, is you can also do harm with these if you pick the wrong size. So if it's too short, it's not going to do its job and it's not going to get air to the back. If it's too long, it's also once again not going to do its job and it's potentially actually going to obstruct your airway and make it worse. So how you measure it is from the angle of the mouth. So good old, so the angle of the mouth to the angle of your mandible here. So if I measure this one on the patient, so going from the mouth to the angle, you can see there, hopefully, that this one's a little bit too long. So not the ideal size for our patient. But if I measure this one from the angle of the mouth to the angle of the jaw there, we've got a nice fit. So this would be an ideal one to slip in. Unfortunately, this little guy is not going to tolerate one. He's got some plastic inside his mouth. But essentially, if you're going to place it, ideally, you would like to use something like a tongue depressor to depress away the tongue and then to slip your OP airway in over your tongue to the back of the throat. We'd say to rather often maybe commonly used in the old days, I mentioned, is to put it in backwards and turn your OP airway around. We try and avoid this because it's of the worry of actually damaging the back of your throat and potentially cutting the back of your throat, especially in your younger patients, which would cause a bigger problem than the one you already have. So rather use a tongue depressor. If you really can't, you can sort of put it at a slight angle to help you get it over and then move it through. Yeah, I think that's the OP airway. What about the nasopharyngeal airway?
So nasopharyngeal airway is awesome. We unfortunately don't have one here, but essentially if you can have a look at this tubing, I'm going to use the suction tubing to illustrate. It's going to be a bit thicker and it says nasopharyngeal. So it's going to go from the nose, down the back of the nose, into the pharynx and sit there. So you need to measure it just like you need to measure the RO. So this time, instead we go from the corner of the nose and we want to go to the lobe of the earlobe. So that would be your measurement. So from the corner of the nose to the earlobe this time. And then that would then sit, you would just thread that down the back of the nose like you would in a NG tube and it would sit there. A lot of the nasopharyngeal airways are actually one size and they're silicone, they're a silicone sort of tube and you stick a safety pin in on the point that you measure. So for instance, if I've measured here, and this is a longer NPA, you would just put the pin through there and stick it in the nose. The nice thing about nasopharyngeal airways is they don't cause a gag reflex because they sit in the nasopharynx. So you can use your slightly awake, sleep apnea kind of patient. You can stick one of those on and stick a mask over and help with oxygenation. And the other thing is if you're really having a difficult time bagging a patient or just pre-oxygenating them, you can stick both an oral pharyngeal airway and a nasopharyngeal airway at the same time and just open up the airways completely. Yeah, I think Henry is done. We can put him away.
Let's put him away. So the next thing on our stop IC bars is the R, which stands for our rescue devices. So within our rescue devices, we often talk about our LMA, which really can be something that might help you to pre-oxygenate in a difficult pre-oxygenation, or if you fail to intubate your patient and you're needing to maybe bag them up or bide yourself time while you make a plan as to how to improve your chances of getting this airway in, you can bag them with this LMA. Obviously, similar to your OP airway, it is going to the back of the throat, so your patient can't have a gag, otherwise they're not going to tolerate it. This one, so essentially this is a laryngeal mask, and as I said, it's a mask that goes over your larynx. So the hope is that it will direct air into your trachea and away from your esophagus by blocking your esophagus with this tube that you inflate. LMAs come in different sizes. So the best way to pick if you've got the right one for your patient is there is actually often a weight on the LMA. So this one is for a 30 to 50 kg patient, so it will probably work for sort of a small female or an adolescent. How you place it is, so we often say either have the mask part of it partially inflated on putting it in, or completely deflated. You just need to make sure that it's completely flat. And if you're taking all the air out, you flatten it, that it's completely flat. It's not bent or curved at any point. So it will inflate nicely at the back of the throat. A trick to, if you are removing it, is don't deflate it when you remove it, because secretions and stuff are going to accumulate above it, and you'd rather pull it out and take all those secretions with it than deflate it and allow those secretions to trickle past it into your trachea. Also, can sometimes be a little bit difficult to place. You might want to put a bit of KY jelly on. If you are putting any jelly, just make sure though you put it on the top. You don't want to put any on this side or the surface that you're going to try and ventilate through, because you don't want to block those holes. So make sure you put it on the top, and might help you put it in. And similar to your OP, you can use a tongue depressor and help you push it down. Other LMAs you might come across is something called your eye gel, which doesn't have an inflatable sort of cuff. It has, its material has some sort of reaction with the secretions at the back of the throat, and it changes shape and molds to make a seal. So those ones you won't see this, you just basically push them into the back of the throat. The next one, I see you getting it out there, is
our video laryngoscope. So this is our video laryngoscope at our unit. We are lucky to have a video laryngoscope, and not everyone does. But you have to, a video laryngoscope is not your get out of jail free card if you don't know how to use it. You have to know how to use your own. They are all very different. This one has the screen on the actual laryngoscope head. A lot of them have the screens mounted on a trolley. Some of them have preset introducers that you must use, and they all have their own little finesse about them. So for ours, we talk about the sub-A view. So you go in and you have a look with your video laryngoscope, and you see this beautiful view of the cords, and you try to intubate and you will fail every single time. With ours, you have to pull back, you have to get the B side view, and then you'll be able to intubate. If you try this in a difficult airway, you are going to battle. It's going to put you off. So you need to practice. If you have a video laryngoscope, you need to practice with yours over and over again in the sim lab, but more importantly, on your easy airways. Not that there's ever an easy airway in the ED, but the easier airways, the ones you're not expecting trouble on.
You really need to be familiar with your video laryngoscope before you try and use it on the difficult airway.
Yeah.
So I think the last on our list then is for ACE, is surgical airways. Not something we're going to necessarily go in fully here on this talk, but those are basically your surgical crutches. And those are used in the instance when you can't intubate, can't ventilate. So essentially, if you can't intubate, but you can ventilate, then we would rather ventilate the patient until you can make another plan to improve your intubation. So that could be ventilate with an LMA or a bad mask valve to bide your time, and then you need to make a plan, call someone before your next attempt. But if you're really in that situation where you can't intubate, can't ventilate, you now need to make a plan. Your next option is the surgical airway. So important to go research, look where your hypothyroid membrane is, and know the equipment and have it available. So you should have a surgical airway equipment available on every resus trolley. We like to do it in our unit. We've actually made little boxes so that it's not like trying to find all the little pieces and putting it together. There's a box, and that box is actually cable tied shut, so no one can go in and steal any piece of it at any point. If you open that box, then the cable ties are broken, and at that point, then you have to restart it and close it again. It's important to consider making one of these. You don't need much. You just really need a blade. You need a size 6 tube. You need something to secure it, and you're pretty much A for away. Yeah. I would recommend, though, maybe there are a lot of videos on YouTube, or we can always discuss at another point. You can let us know, but also something to practice in your sim labs, obviously not something you practice on your patients. That is really at the point of when you really are stuck. But something to be able to do and have all the stuff ready. So you don't want to go into any airway without being ready for a surgical should it be needed.
Sure. we have prepared the patient, we have lemoned them, we have now prepared for the airway, we have stopped icy barred it. Now we need to prepare the people
ourselves. So I think this goes with the name of our talk, Just Breathe. So now that you've pretty much prepared and you really, I think, put yourself in the best position to have first class success, but now you need to take a breath, let your team take a breath, and then make sure your team and you know what the plan is. And obviously we always love closed loop communication, but make sure everyone is on board on what their role is and what your plan is. And I know in Livingstone, you've got a very nice way of going through it with your MOs. I don't know if you want to just take us through that.
So we ask everyone to tell the room what your plan is. So you will say, my first attempt is going to be with a direct laryngoscope to pass an ET tube. If I fail, I'm going to come out and I'm going to bag, either with a bag valve mask or with a laryngo mask until the SATs are 100%. And my second attempt is going to be a bougie assisted airway. And if I fail that, my third attempt is going to be, I'm going to ask my consultant who's standing next to me, or I'm going to put an LMA in and make another plan, but you basically say to the room, this is A, B, and C. Everybody knows what's coming. Everybody knows if there's something failed, we have got a backup and there's no floundering. So we like to talk to everyone. And then the other one, prepare yourself. We've talked about positioning the patient, but position the patient in perspective to you. So if you are really tall, make sure the patient is on a bed that you can lift it. So you do not want to be bent over into an airway. If you are short, please make sure you find a stool. You cannot be peering into the airway. And make sure the patient is at waist height, basically. Waist height is the best. And then you have a thing about the bed.
Oh, so the other thing is make sure the patient is not down the bottom of the bed. You can't intubate patients halfway down the bed, and you don't want to be climbing onto the bed to get to the airway. So make sure you pull the patient up and the patient's head is as close to the edge of the bed. Obviously, you want the appropriate bed, so ideally a bed that goes up and down and doesn't obviously have a back and a front, because you need to be able to get to the back of the bed to intubate. I think are we happy that we prepared?
Almost. I've got one other thing. When you prepare yourself, I know we've just come out of COVID and everyone's like full with this, but PPE, you have to be wearing PPE. There are so many people that have got TB intubating patients. Please, if you don't wear an N95 all the time, which I would urge you to do, but I know most people don't, this is the time that you should be wearing an N95. This is also the time that you should be wearing eye protection. So prepare yourself. TB is not something you want to get. And nor do you want to end up on ARVs or something because you have a really contaminated eye splash.
So don't forget, we must never forget ourselves in our own protection.
Okay, so I think we have prepared. Are you going to tell us about pre-oxygenate?
Yes. So now, okay, still preparing. You need to pre-oxygenate the patient. And ideally, I like to do this once I start thinking about intubation, because pre-oxygenation is not an immediate thing. I think the standard is 8 vital capacity breaths or 3 minutes of 100% oxygen. So it's not something you can just whack on just before you put in the drugs. So you're thinking about intubation, you think you might not, but while you're busy preparing, put on and on, you breathe onto your patient. Or obviously if your patient is not breathing at all, start bagging them. Or if they're really hypoxic and struggling, this is the time maybe you want to put some CPAP on and pre-oxygenation them with CPAP. But the importance is pre-oxygenation. And that's why I've placed this desaturation curve here. So this is basically how long, so on the y-axis is your SATs and on the x-axis is time. So it shows how long it takes you to basically desaturate to 0 so most of the lines are from 100%, but one of them there is from like 94%. But basically it shows you if you've got a healthy adult, you've probably got there, looks like about 6 minutes before they start desaturating. And then you can see once they desaturate very fast. And by 10 minutes, you're probably going to have SATs of 0. So I think this is where people hope sucks will be great, because sucks also kind of works for about 5-6 minutes. So maybe you'll be okay and they'll stop breathing, the sucks will wear off and they'll start breathing again. But as I say, once again, can't hang your hat on that. Obviously, it shows, though, that if you've got a child, they're going to desaturate a lot faster. So even a child, if you pre-oxygenate them to 100%, they will drop off and drop off very fast. You can see how steep that curve is at about 3 minutes or 2 minutes. The same with an obese adult or someone that's got a lot of chest and weight in their chest, or difficulty or decreased lung volumes, maybe your pregnant patients where they've got decreased vital capacity and stuff because of that pregnant abdomen. So those patients are going to desaturate very fast. And that's if they're really starting at 100%. But a lot of the time our patients that we've been intubating for lung issues and ventilation issues, we can't even start at 100%. So you can see there, that one is starting around 94%. That patient's dropping off at about 3-4 minutes, and by 6 minutes they've probably got SATs 0. And that's, I think, even a good case for a sick lung patient. I think we all got to know with COVID how quickly people can desaturate. So it's a very, very, pre-oxygenation is a huge key. So things, as we said, one thing, as I said, a non-rebreather. Another option is what we've used and came out a lot in COVID is double oxygenation, double barrel oxygenation. So you actually put the nasal prongs on and you put the non-rebreather on. That nasal prongs can actually go for the whole period of your intubation. And often what we like to do is actually crank it up to like 12 liters per minute, 15 liters per minute while we're oxygenating, to give what we call passive oxygenation, to try and wash out that nitrogen and try and give as much oxygenation as you can, even while you're intubating. I don't know if you have anything else to say on that, but I think just the key thing is don't pre-oxygenate is so important, and start it early. Your patient can sit on the non-rebreather for 10 minutes while you prepare. If they sat to 100, that's great.
Exactly. Yeah, I think you've said it all. So once we've pre-oxygenated, we need to paralyze and induce our patient. I think we have discussed our table quite nicely. I think the only thing to reiterate is that it is a push-push. So you choose your 2 drugs. It's you push your induction agent, you push your paralytic agent. There's no time in between the 2. We're not anaesthetists, we're not waiting. You are going to then wait for your paralytic to have onset, which, as we said, is approximately 45 or 60 seconds, or until the fasciculations go. And in that time, are you going to apply cricoid pressure, Mary?
So, no.
Okay.
So cricoid pressure is another thing, such as also with the ketamine and these long-standing things, where people thought you had to give cricoid pressure to prevent aspiration. It's actually been shown that we aren't necessarily very good at giving cricoid pressure. It's often given incorrectly. It takes manpower because you have to have one person dedicated just to giving that cricoid pressure. And also we don't actually know how much pressure we're giving. So we might actually be causing more harm than good. So generally cricoid pressure is out. What I might do though is something called BURP, which is backward, upward, rightward pressure. And that essentially is actually to improve my view. It's got nothing about cricoid pressure. And how you do that is when I'm intubating and I've got put my laryngoscope in and I'm actually looking at those cords, sometimes by just adjusting the, just on the outside, by just fiddling a little bit on my thyroid cartilage there, I might just be able to improve my visualization a little bit. And what the best thing to do is to position that in the best position yourself, and then to ask an assistant just to take a hand and just to keep it in that place so you can continue with your intubation. It's obviously just a short period of time. Generally one hand, it's a lot less manpower than the cricoid pressure. So no, you don't need to give cricoid pressure. But yes, you might want to do a bit of adjustment to that thyroid cartilage to improve your view.
Okay, so do no harm. Stacey, no cricoid pressure. You're probably doing harm to your patient. Okay, so the 4th P is pass the tube. So you just drop the tube. You do basically just drop the tube now because you've prepared so much and you've made this intubation as easy as possible, as optimal as possible. All the axes are aligned and the drugs are right and everything. So I pass the tube.
So, well, when you pass the tube, I hope you're doing it under direct visualization. Because firstly, remember I said, even if you're using the bougie, you never lose sight of those vocal cords until that tube is pushed through and you can place that. But Nicola, do you want to quickly go through to me how you're going to check that your tube is actually in the right place?
Well, I saw it then.
Okay, so that's great. So
okay,
that's one way. But we like to just triple and quadruple check.
I'll give you all of them. Okay, so we'll start clinical, then we'll go monitors, and then we'll go investigations. I'm really sorry, but the cat wants to join.
Also likes AIRWAY.
Okay, sorry. Okay. So in terms of checking if the tube is there, I'm so sorry, this cat really wants to join the airway talk. Okay, so clinically, I'm going to see it go through the cords. I'm then going to look at the chest, and I'm going to hopefully see bilateral chest rise and not abdominal rise. I'm going to have a look at my tube and see misting of the tube. None of these are absolutes, but as soon as I've passed this tube, I'm going to ask my assistant to grab the stethoscope and have a listen. The first place I want them listening is the epigastrium, always the first place. If you bag and they hear bubbles over the epigastrium, you need to remove that tube. Don't sit and stress about, oh, is it possibly, but I thought, just take it out. It's in the esophagus. If it's not, if you don't hear any bubbles over the epigastrium, left axilla is the place to start, because if you hear breath sounds in the left axilla, you most likely have the tube in the correct place. But don't panic if you don't hear it in the left axilla. Have a listen in the right axilla, and if you hear breath sounds in the right axilla, you may have tubed the right main bronchus, and the right main bronchus is easy to slip the tube in. That left bronchus has got this hyperacute angle, so it's very difficult to get it into the left, but it quite easily slips into the right. So if you hear them in the right, pull back 1 centimeter, have another listen on the left, and keep pulling back 1 centimeter and have another listen until you have equal breath sounds on both sides. We'll come to that just in a moment, just length. But other than, so we've had a listen, we've had a look, then we are going to have a look at our monitors. So the monitors next, have a look at our sats. They don't go up straight away. There is a bit of a lag, but we're hoping that we're not continuously falling. So over 60 seconds, we should start to see the sats pick up. They should hopefully not be going bradycardic. That would be a sign of hypoxia. And if you have a capnograph, that would be amazing. That would obviously be the best confirmation of your tube. And then lastly would be your modalities. So your chest x-ray. Chest x-ray will tell you about the depth of your tube, but can't differentiate between esophagus and trachea. And it's too long to wait to get a chest x-ray. So you should have some confirmation before. Or you can use your ultrasound if you are keen ultrasonographers or keen ED ultrasound gurus. Yeah, you can check for lung sliding either side, but you have to know that there are obviously issues with that. There are reasons that you might not have lung sliding, or you can actually look for the tube in the past the vocal cords, but it's also quite a specialized thing. But if you have it at your hand, or you want to start thinking about figuring that out with your ultrasound, it's a good way to do it. Yeah, with regards to that length of tube, there's some good rules of thumb. So if you've got a female, you're hoping to see their tube sitting at about 20 centimeters at the teeth, and a male 22 centimeters at the teeth. So if you're seeing a much more shallow or much more deeper tube, ask yourself, do you think it's in the right place? Obviously, these are rules of thumb, and if you have a very big person, it may be a lot deeper and you may still be in, but it is something. If you have your normal sort of 75 kilo adult and you've got your tube sitting at 26 centimeters, you may want to ask yourself, are you sure you're in the right place? Are you not in one of the bronchuses? Yeah. Okay.
Exactly.
So I think I'm in.
Great. So now we move on to our post-intubation.
Yeah.
Finally. So post-intubation, so we're happy that our tube's in. I think the next thing we have to do is connect the patient to our ventilator.
You're not going to bag him the whole time?
Ideally not. Firstly, I might have intubated them for a oxygenation problem that I might need to try and assist with my ventilator. Also just the manpower to do it. I know, unfortunately, sometimes we have no other options and we don't have any ventilators available, but really the next thing you intubate the patient is to place them on the ventilator. So we've just put up a few basic sort of how to start ventilation for anyone. We're not going into the ins and outs of ventilation. I think the first thing I'd say to everyone is, if you're new, you're junior, you're just figuring it out, just know one mode, learn one mode, know it well, and be able to manipulate with that. Often we say the best one to start is probably volume, and volume 8C, which is assist control, is generally the starting point. Remember, these patients do need to be sedated to have an assist control ventilation mode. So that is another thing in your post, is to get sedation, but we'll go into that now. But just basically basic mode. So if you've got a patient with normal lungs, we generally want just a standard respiratory rate of 12 to 14 is probably okay. And we just want tidal volumes within sort of our safe levels, we say 6 to 8 moles per kg, and a standard basic normal IE ratio of about 1 to 2, stats on FiO2 to maintain stats between 92 and 96%. And important with your FiO2 is that we really want to use as little oxygen as possible to maintain those stats, because we are worried about oxygen-free radicals from using higher FiO2s. So we don't really want to keep oxygen at 100% FiO2. We want to try and downtitrate that to 40% if we can, as soon as possible once intubated. And then the last one on the list is PEEP, generally just to maintain our alveolar opening and to assist that ventilation and the opening up of the alveolar for every breath. We generally say for normal lungs, a PEEP of around 5 is probably sufficient. Obviously, we're not always ventilating normal lungs. We've often got our sick lungs. And for them, obviously, you can think patients when they're sick with lungs, they're tachypnic, so we often got to go for a higher respiratory rate, around 14 to 20. A big worry with sick lungs is volley and barrow trauma. So we like to say to keep our tidal volumes on the lower end of normal. So we don't really want to go near the 8. We're going to try and stick it at 6 mils per kg. Our IE ratio, 1 to 2 should be fine. Maybe you need a little bit longer time for expiration. You might look at 1 to 3. Once again, stats at 92 to 96%. Obviously, these are often hypoxic patients, so sometimes FiO2 needs to be higher, but we also emphasize a lot on PEEP and how PEEP and helping to open up alveoli can help that oxygenation. And as I said, we want to keep our FiO2 on the lower end, so you can also use your PEEP to help assist your oxygenation. So if you notice you're going up on your FiO2, also potentially go up on your PEEP. So we say anything between, I think it's around 5 to 10 PEEPs for your sick lung. So they are, that is something you can go and look into if you want to understand it further, but that's a basic approach to ventilating the sick lung. And then there's your obstructive lung, which is essentially your asthmatic. And I think none of us really want to ventilate an asthmatic. They are difficult. So we'll do everything we can to make sure we can medically manage them and hopefully avoid intubation, but sometimes we actually just have to. And then we do need to do it. So for them, because the problem is often expiration and air trapping, we actually want to increase that expiration time. So our aim is then to do a lower breaths per minute to try and get more time to exhale that air. We're not so worried as much about sort of the damage of the lungs with the volume barotrauma. So we say the tidal volume can still be around 6 to 8. But the important thing here is the IE ratio to sort of extend that so that we've got a long time to exhale and try and get that air out and decrease that air trapping. So you're going to do around 1:4 to 1:5. Once again, you want to just keep your stats between 92 to 96% with the lowest amount of FiO2 that is required. And then with the PEEP, once again, so the biggest problem is air trapping and they're kind of blowing up like balloons. So we actually want to go on the lower side of PEEP. So we're actually going to go to like 3 to a maximum of 5. So you're really going to keep those PEEPs on the low side. So this is just a table to sort of basically help you start and set the ventilator initially. And obviously then there's some fine tuning and sometimes you might just need to call for help if you're struggling. I think that's your ventilator setting. The next thing you want to mention is probably sedation.
Yeah, if you put someone on a ventilator, they must be sedated, maybe have some analgesia. Yeah, it's not a pleasant procedure.
Exactly.
Yeah, and then the other thing is if you put someone on an ET tube, they need a catheter and an NG tube. You can't have large bladders, and you need to decompress your stomach. So those are one tube gets 2 more tubes, NG tubes and catheters. And
the other one is monitoring. I think we have mentioned it a lot, but you know, can be an unstable time. Firstly, they're probably unstable before. Now they're going to have a period of apnea. The drugs themselves that we give for the induction can drop your blood pressures. Also, when you're tapped into the ventilator, you get a change in your positive pressure, which can also decrease your venous return and drop your blood pressure. So you need to have them on monitoring. You need to have sort of a plan in place, maybe some inotropes or some push dose presses or something available should your patient become hemodynamically unstable during that period.
So that actually leads quite nicely into your ventilators are alarming and your sats are dropping, and what now? Obviously, we have another mnemonic.
So dopes. So dopes is the mnemonic for your patient who's desaturating on the ventilator. And my key, before we even start with dopes, is if your patient's desaturating on the ventilator, disattach the ventilator, put them back on the BDM. Because if it is an equipment problem or it is a ventilator or a ventilator synchrony problem, you're removing that problem immediately. You also, by attaching them to the bag bath, the BVM, the bad word mouth, you actually also can get some tactile, sometimes idea of what's happening within your airway and the pressures and things that you're dealing with. So, but you are dopsomonic. The D is for dislodged. So tubes can move, lifting patients from one bed to another for x-rays, suctioning the patient. Tubes can get dislodged. So firstly, check your tubers in. Are you happy? Check in your lungs again. Look at your capnograph if you've got one. But is your tube in the right place? Has it moved? If it's obviously, if your tube's out, you need to sort of start again and re-intubate the patient. I think so. O is for obstruction, and I can see you brought the other section, Gqeberha, out.
This is where the flimsy one comes in.
So is there like secretions or blood or something in your tube that is just obstructing your tube and your vent is complaining of high pressures? So maybe you just need to give your tube a bit of a suction. And then lastly, pneumothorax. Do you want to?
Yeah, so you can blow pneumothoraces whilst you intubate, whilst you bag valve mask, just these high pressures. So once again, it's clinical suspicion. Have a look. Chest, what's the chest rise like? Is it hyperresonant? If you have an ultrasound machine and you know how to use it, to diagnose a pneumothorax, you might have time for a chest x-ray. Just keep it in mind, it is one of the complications and it needs decompression, just like any other pneumothorax, and it needs an icy drain.
Yeah. So don't forget about your pneumothorax, especially, barotrauma is a risk and it is a complication of ventilation.
Particularly in peds and asthmatics. Those are like the two big ones. You think you haven't overbagged a kid, and you've blown a pneumo. It just happens so quickly.
Or your trauma patient that maybe the pneumo was small and you missed it, and now you've intubated and you've sort of blown that pneumo bigger. So especially if they're tensioning, you need to decompress and get your icy drain in. And then the last two, E is for equipment, which by just removing the ventilator, we really troubleshooted that, hopefully. But then you need to think why. So if your ventilator is not working, you need to get a new ventilator, you need to get a technician in, or you need to look at your settings or check all your connections. But ideally, don't just turn it on and off and hope for the best. You need to have approached it and decided why. And hopefully, if you're unsure, hopefully you've got a second ventilator and you can just move them across until you can address the problem with that one. And then the last one is synchrony. So synchrony also with events. So sometimes this one comes big, maybe if you haven't sedated your patient appropriately, so this can also be event setting related, but generally in our setting in the EC, you can overcome it with sedation. So just look at your sedation.
Or reparalyze
the patient. Obviously, if you're paralyzing, just please make sure that you've got some form of observation in your unit, that you're not paralyzing a patient in one room and everyone is then going to see a patient in the next room, and that patient comes disattached from the vent and he's not breathing or something, and he actually just becomes apneic and down. So paralysis is great, but make sure that you've got appropriate sedation and that you are monitoring the patient. But synchrony, basically, if they're breathing against the vent and they're fighting it, you're going to struggle to ventilate.
Yeah, sure. We really have covered most of the airway. We just sort of want to touch on one or two of the difficult ones that you are going to come across in your emergency department. So one is the hypotensive acidotic patient. So this could be the trauma patient or the medical patient. If they're hypotensive, don't reach for the airway first. They need to be resuscitated first. So whether it's fluids or bloods or doing trauma, sorting out splints or pelvic binders, sort out the hypotension first. If they need inotropes, you start them on the inotropes first. Remember, all your drugs are going to make them crash. All the drugs that you need to help you with your airway, that you really need to help you with your airway, are going to cause things to be much worse in a non-resuscitated patient. And then that hypotensive patient is often very acidotic, and often these acidotic patients are breathing off all their CO2. And when you have a look at their PCO2, it's in the shoes. But then you go for an airway, they have this apneic period of at least a minute during the paralysis, and you fiddling to get the tube in. So 60 seconds before 120 seconds before they breathe again. And by that time, their CO2 is well risen. And now they've become increasingly acidotic, both from their metabolic state and now the CO2 that's causing a respiratory acidosis. So you need to match that minute ventilation, be cognizant of their pre-intubation respiratory rate and match it post-intubation.
So that's really one of the tricky cases where you need to sort out the other stuff first. You need to maximize the whole point in this talk is about maximizing your chance of success. And this one, you really have to prep your patient. You need a resuscitated patient before you head for the airway. Often the airway can wait that 10 or 15 minutes to try get a patient onto an inotrope infusion. And then the other big one that we see that's always an issue, we sort of touched on it, was the neuroprotective head injury patient or intracranial bleed.
Yes, so any patient with raised intracranial pressure, we just want to try and make sure we don't worsen that intracranial pressure. So we've already said that ketamine is not an issue, so that's fine. You can still use your ketamine as an induction agent, but you do want to try and what will blunt the intubation response. So often people with intubation will get a tachy and a hypertensive sort of spike while we pass that tube. And so we can try and do what we can to try and decrease that. And one thing is to give an opioid like fentanyl, which technically tries to help blunt that intubation response. So that can be done. Fentanyl takes a little bit of time to work. So it's something nice to give while you start pre-oxygenating, to give a few minutes for the fentanyl to work. So while you're pre-oxygenating, while you're preparing, just give 20, depending on your stability of your patient, 25, 50, 25 nights of fentanyl, hopefully just to blunt that intubation response. And then once you've intubated or during intubation, just don't forget that your kind of head injury kind of procedure that you can try to sort of decrease your ICP. So if you can put the head at 45, you want to keep their blood pressures up. Another reason to make sure you sort of pre-resuscitate it, because you want to try and prevent any hypertension. Make sure you pre-oxygenate nicely, try and decrease your apneic time, decrease any instance of hypoxia that can worsen your brain injury. So it's all about trying to prevent those secondary brain injuries. Good sedation once they are intubated, so that they don't sort of wake up fighting once again, also spiking their blood pressures and getting tackies. So yeah, it's all about thinking and approach and trying to optimize your situation. I think just the last one is obviously, I think we've actually discussed this, is the hypoxic patient. So if your patient is profoundly hypoxic, do the best you can to pre-oxygenate before you intubate. So whether that is with nasal prong and a non-rebreather, whether that's with CPAP, is obviously we mentioned with the nasal prong, you can do that passive apneic oxygenation while you're intubating. Just keep it in mind because of those desaturation curves that we showed you.
Yeah, now we really have done it. And we can just breathe.
But yeah, I don't know what the time is. I hope you guys haven't fallen asleep. But yeah, I don't know if you have time for any questions, or you can always get in contact with us if needed.
Well, if I could just say, thank you very much. That was awesome. It was a great presentation. And it's lovely to have it such an interactive, practical session. So I really appreciate that. I'm just launching the poll. So that's just a little bit to get feedback. I don't think you guys will be, I don't know if you'll be able to see it because you're co-hosts. Ignore question 3. That was me being in a rush. Question 3 is not a question, but please, if those of you watching, if you could please fill in the poll. So just give us a bit of feedback and also proof that you've been watching. But yeah, we are very happy to take any questions. You can either put up a hand or you can put a question in the chat, and I will keep an eye on that. Just looking if there's anything showing up at the moment. But we are going to be having monthly webinars throughout the year, and we would love to have you guys do some more practical sessions because this was really great. So, and that's always one of those tricky things to learn, because you sort of live in the scenario where sort of you learn, you know, it's the do one, see one, do one, teach one method quite often. And it's very nice to actually be taught by specialists in the field. And in emergency medicine, we don't often have that opportunity to sort of have the definitive answers. You quite often have boermaker plan that just gets passed on from one to the other. So we would love to invite you to one of our webinars again in the future, if that would be possible.
Thank you. Yeah, we'd love to come.
I'm just looking, there's no questions that I can see at the moment, either in the chat. I think that was a very comprehensive talk, and we are going to obviously record it. And we always see there's actually even more people that watch afterwards on YouTube than on the evening. So this is the gift that keeps on giving. So thank you very much. I'll stay on the call for a few minutes just to do all the admin, but yeah, I would like to thank you both very much for making the time this evening. And we do hope to see you again later this year. And then next week, guys, we'll be moving on to a talk on anesthetics from David Bishop. So he's an anaesthetist doing lots of rural talks in KZN, and he'll be, I must just check you that he'll be talking about some top tips for district anesthesia on Monday night. So it's going to follow up a little bit on what we were doing here as well, but in a different vein. So thank you very much, everybody. And I think, oh, hold on, there's a question. So there's a question: what drugs do you recommend using for sedation while intubated while awaiting transfer to higher level centers? Oh, very practical question. Quite often by the time we intubate means we're going to send somebody somewhere else. So some last comments on that before we close.
So I think it does depend on what you're comfortable with, and different places have different different protocols. But the most important thing is to look at your patient's hemodynamics, because when you start them on drugs, usually all of these sedatory drugs or analgesic drugs have hemodynamic effects. The most common one for people to mix up would be a midazolam and a morphine combination. Absolutely fine if you have a hemodynamically stable patient. Very low doses must just be titrated. It also does depend on how you're going to be giving this drug. Have you got an IVAC or a syringe driver? Because otherwise it's a little bit difficult to be using the two drugs. If your patient is not hemodynamically stable, you've got a trauma patient or a previously hypertensive patient, I'd be looking at using a ketamine infusion, or probably small boluses of ketamine. So you're going to be looking at one, have you got a continuous infusion versus bolusing, and two, hemodynamics. If they're sort of on the lower end of the hemodynamics, a little bit unstable, ketamine. Otherwise, for most, morphine and midazolam works quite nicely, and you can mix them in combination if you have a syringe driver, and if you're giving them as boluses, just small midazolam patient.
You need that analgesic dose. Which are all easy.
I think
Does that help?
I think that we lost the last 20 seconds on my side, but I don't know if it's my reception or just general reception. I think load shedding is kicking in somewhere. But we heard the introduction around morphine and midazolam, just the last sentence.
Did you hear about versus ketamine?
Yes.
Okay.
Yeah.
Basically, the last sentence was EM guidance is your friend and has all the doses and the sort of sedate, the infusion protocol. So if you're looking for doses and you're using EM guidance, you have it all at your fingertips.
Perfect. And that sounds like an excellent last place, and always go back to the box. If you do have any of your lovely acronym posters that you've sort of adjusted for own use, feel free to share with me. So tomorrow we'll be putting out the resource packs for the emergency medicine sections. We do have a Google folder, and I'm very happy to share those for people who want to print them out and put them in their own casualties.
We do have a great one that covers